bifurcation lesions are always challenging, and it's encountered in 20% of day-to-day interventions. Provisional stenting is always considered as the best strategy in most of the situations, but in 1 in 5 patients may need an elective 2-stent strategy. We encountered a patient who had a challenging tandem lesion, bifurcation, one in the left main and another in the proximal LCX OM, and just I'm here to present how we managed by this today. So, DK crash, among the 2 stents technique, DK crash has been favored by all because of the data, because this can achieve a very good stent apposition and stent expansion in the side branch among all the 2 stent technique. But several technical refinements to DK crash has been proposed by various authors in the last 2-3 years, starting with aggressive dilatation of the port dilatation of the side branch, then comes the nano crush, then we have a reverse tap, reverse T stenting. These are the new ramification which has come, which has been studied not in a very good numbers, but has been tested against DK crush and found to be non-inferior to DK crush. So here is a patient, 76 years age old lady. He came to us with severe new onset angina and heart failure symptoms. This was a ECG coronary angiogram pictures. You can see the tropi was positive, ejection fraction is around 40%. And this is, you can see a very high grade stenosis involving the proximal bifurcation involving the LCX and OM. And you can see from the angiogram, you can see there is a 0-1-1 bifurcation lesion in the left main also. So this picture you can see how it is very much calcified, this bifurcation, 76 years old female patient. And so we did OCT. So OCT plays a very crucial role in any left main intervention. So we choose the right radial approach with 6 French EBU, and after OCT we could see that there is a significant lesion in the distal left main also. The MLA is around 3.5. So we want to do elective provisional stenting to the LCX OM bifurcation. After that, then we want to do the left main by because these 2 bifurcations are very close by and it's very less than 10 millimeter. We want to do one of the new technique which has been proposed for any bifurcation is the reverse tap technique. So we started with doing the LCX OM bifurcation. We pre-dilated with the 2x10 balloon. There was very difficulty in going the wire into the distal LCX. So we took the help of filter FC and wired both the LCX and OM. We took the help of guide plus extension to take the balloon down, and we dilated adequately. We prepared the lesion. We used a Wolverine cutting balloon to prepare both LCX and OM. We were planning to do LCX OM as a provisional stenting, but since we have to land LCX stent in such a way that it will be just at the ostium of the LCX with a very minimal protrusion. It's like a reverse tap technique we were planning to do. And after stenting the LCX with 2.5 into 18 millimeter drug-eluting stent, a part was done. There is no actual space for doing part, but we were able to do we are going to do the left main stenting. So we were able to do part, and we rewired and do even kissing dilatation to the LCX OM, and we could achieve a very good optimal result in this. After that, the reverse tap technique. This technique is just, I will show the few steps in the few moments later. So after pre-dilating and preparing the left main and LAD lesion, we used 3 into 38 millimeter drug-eluting stent, and it was stented from the left main to the LAD as per the OCT dimensions. We took 3 into 38 millimeter stent, and we did a part recrossed and did a final kissing dilatation to the left main bifurcation, and the OCT images showed a very good apposition without any malapposition in the left main, and we could achieve a very good result of more than 80% expansion in the entire left main and LCX stent. We took a 4 balloon for doing part in the left main. So this is the OCT image. You can see a very nicely expanded stent in the left main, and you can see the bifurcation showing almost a near, very less neometallic carina. In this, you can see that. This is a post PCI angio showing very nicely deployed provisional stenting to the LCX OM and left main to LAD stenting. So coming to a few words about these steps in the reverse tap. It is like a side branch we are going to treat first. The main disadvantage I will tell is you have to do it's a two-stent technique. The angle is also very important. If you have an appropriate angle, you can place a stent with very minimal protrusion. What's the main difference between this technique and the DK crush is we are going to now do only one-time recross and one-time kissing. And it has been found in a small study, and it has been compared with the DK crush. And we were able to, here only we are doing first sequential dilatation in the main vessel and the side branch as shown in this picture. And this is the thing, and it has been useful, very useful. This alternate high pressure dilatation of the main branch and side branch balloon following side branch stent implantations is used. This is used as a substitute for first kissing balloon dilatation. The rationale of this step is it allows circumferential distribution of the side branch stent instead of the crushing of two layers of stent on the main vessel. So that's why it's definitely easier to recross only one time. Very quickly we can do it when compared to the regular DK crush. And this can be used in emergency setup, very useful in very emergency setup especially. So this is a small randomized study done in around 50% tip-tap randomized trial. And it has compared, it's a non-inferior trial with the DK crush, and it has been shown that this technique is a very easy technique and safe technique, can be done, but imaging is mandatory. If you have imaging guidance, then definitely you can use this technique and treat a lesion to have a complex bifurcation. So to conclude, reverse tap is a safe, simple, and can be a new reliable alternative for bifurcation lesions that need two stents, but we need more data to support this technique. Thank you.